Thank you so much for the very kind introduction and actually covering some of what I was going to talk about, which is excellent. And I'm very grateful for the opportunity to present. This is my first time in Turkey, first time at this Congress, but I had actually heard a lot of great things about this meeting, so I'm really pleased that I can be here and share this discussion with you. As was mentioned, my thesis most recently was around placebo effects, not just in anxiety disorders, but in gambling and depressive disorders as well. But one of the things we focus on in Southampton is understanding the mechanisms of anxiety disorders, mainly to discover new treatments for anxiety disorders. And it was really that work that's led to my interest in placebo effects, and I'll kind of explain a bit about why that is shortly. So in this talk, I'm going to talk a bit about some background about the placebo effect, mainly in anxiety, to begin with, and then talk a bit about some of the research questions I've been grappling with and some of the most recent research I've done. And then hopefully there should be quite a lot of time at the end for questions and a discussion. And although the talk is focused on anxiety, I'm happy to talk about placebo effects in other disorders as well, if that interests you. So just to say at the beginning, my work was funded through the MRC, the Medical Research Council, and I'm currently funded by the National Institute of Health Research. But neither of those organizations had any input into my work or this presentation, and nothing else of relevance. So, anxiety disorders are the most common of the mental disorders. This is from Our World in Data, the World Health Organization Global Burden of Disease study, looking at prevalence rates of different mental illnesses. This is for the United Kingdom, and you can see anxiety disorders, 4.5% there, are the highest of the disorders. It's a similar picture in Turkey as well. So this is Turkey, actually very similar prevalence rates, I think, to the UK, which is quite interesting. Again, around 4.5%, slightly less depressive disorders, maybe that's to do with the weather or the food. Not sure, but certainly anxiety disorders are very prevalent, and if Turkey is anything like the UK, they're very burdensome as well. Patients with these disorders, struggle to work, they're not as productive to society, but they also have associated healthcare costs. They have comorbid physical health illnesses, often comorbid mental illnesses. And there's also carer burden too, so these kind of hidden costs of anxiety disorders. And when you add all those up, probably across the EU, across Europe, you're looking at the hundreds of billions of euros in terms of costs and burden. So these are important disorders to try and treat. But our treatments are not perfect. So only about 50% of patients will remit with a first-line treatment for anxiety disorders. That's either medical treatment or CBT or psychotherapy, and that's if you can get access to those treatments as well. If the situation in Turkey is similar to the UK, there's long waits, difficulty accessing those resources and treatments, and they come with side effects, which are not perfect. But developing new treatments is really tricky in anxiety disorders. So this is from a review in 2013 by Griebel and Holmes, looking at the number of different compounds and different experiments that have been done as potential treatments for anxiety disorders. And despite testing around 1,500 novel compounds, only a handful have come through, if that, to clinical practice in the last 50 years. So it shows that there's a real kind of a real drop-off in the numbers of treatments that come through, which is a major issue. There's probably three broad reasons why that is. why it's so difficult to discover new treatments. First is our understanding of the neurobiology is still far from perfect. We're only really scratching the surface of the neurobiology that drives a lot of these disorders. And because of that, our preclinical models are far from ideal. So because we don't understand necessarily what the targets should be of our treatments, we have issues with kind of in vitro clinical models, in vivo clinical models as well in animals, don't always translate in terms of validity. So there's issues with those preclinical models as well. And there's a lot of attention that's been devoted to those two reasons. But I think there's a third issue that's had less attention comparatively, apart from the last few years. And that's the very large placebo response that we see in anxiety disorders, but also in mental disorders generally. This is just to highlight this point. This is a meta-analysis that was carried out by De Vries and colleagues and published in 2016. And you can see on the right of the table here, if you look at the effect size, the difference between placebo and medication groups, you're looking at effect sizes of around 0.3, 0.4, which we would call small effects, small to moderate effects, which is roughly what you'd expect. But if you look within group, you see much bigger effect sizes. So the medication group for GAD, you're looking at kind of 1.35, which is a very large effect. But even the placebo group, you're seeing an improvement with an effect size of 1, which is very large. So the difference there might only be 0.3, but actually a lot of patients improved, and quite dramatically. You see a similar thing with social phobia and with other anxiety disorders too. Probably about 75% of the improvement you see in the medication arm, you see in the placebo arm, which is an issue because that can obscure your medication effect. And in fact, that is more likely to happen these days because the effect size of the placebo has increased over the last 20 to 30 years. So this is from a meta-analysis by Bandelow and colleagues, and you can see across the x-axis here, there's year, the y-axis is effect size, and you can see that over time, that effect size has increased. And this is within the placebo arms. So the effect size of that treatment, if you want to call it that, has increased over time. So what do we mean by placebo? What is it? And broadly, the placebo effect is the improvement you get in a placebo arm that's not due to any medication factor. So any improvement that happens when you've been given an inert pill or other placebo. But that's made up of all sorts of different effects. So some of these will be statistical, right? You get some patients that improve whatever you do. They spontaneously get better. That will happen. Regression to the mean, that is a concept where patients will tend to enter trials when they're at their most unwell. That's when they're likely to seek treatment. That's when they'll go into a trial. But actually, their real baseline is probably a little better, and so they tend to improve over the course of a trial. There might be other biases as well, or other co-interventions that aren't detected, like if a patient during the trial changes their diet, has a new friendship, starts exercising, it might not be the thing you're studying, but it might lead to some improvement for those patients. So there are these kind of unspecific effects, but there's also some so-called specific placebo effects here, which are a mixture of kind of psychological and biological mechanisms. We know that placebo effects involve expectations and learning, and these translate into changes in biological systems. I think something really important to know is that this doesn't just apply to the placebo arm. It also applies to the medication arm, and I'll come back to that. So if you imagine you're going to see a health professional, that will activate some context. There might be paraphernalia in the room to do with healthcare. The health professional might be wearing a white coat. That will activate in your mind some prior contexts about what's about to happen. So that leads to an internal expectation, possibly of getting better, but you then update that through learning. So your expectation that I'm going to improve, if you end up on a treatment that causes side effects, say, that might make you think, ooh, I'm getting these side effects, the treatment must really be working, so that can reinforce those expectations. That then activates biological systems that leads to symptom improvement or a placebo response. These biological systems are quite diverse. Here is a diagram from a review that tried to summarize these. It involves a mixture of all sorts of things: reward systems, limbic emotional systems. We know that you can affect the immune axis and immune system through placebo conditioning. So you can cause immunosuppression, for example, by giving patients a placebo. It activates or affects the HPA axis, the stress axis as well, and cortisol. And possibly most importantly, we know that endogenous opioids are likely to be involved in placebo effects across domains, not just in pain. So there's a wide variety of systems that are likely involved in these responses, some of which are relevant to anxiety disorders. And as I say, this can affect both arms. It doesn't just affect the placebo arm. So here was a really interesting study that utilized a kind of open, hidden paradigm to try and show this and accentuate this. This was in a group of patients who all had social anxiety disorder, and they were all given escitalopram. But the difference is they were randomized to instructions about that escitalopram. So one group, the overt group, were told that they were receiving escitalopram. The other group, the covert group, were told that they were receiving an active placebo, a drug that would cause side effects but would not improve their symptoms. And what you can see is a big difference between those groups. So the overt group was significantly superior to the covert group. The effect size here, actually, the improvement is about 2.2 from start to finish. The covert group also improved because they were receiving escitalopram, but that effect size was only 1.2. So the difference there is what we think is placebo mechanisms, expectations, learning. The belief that you're receiving the actual treatment led to a much bigger response. You can see the same thing in antidepressant trials when you're less explicit about it. So this was in a study where patients with depression were randomized to one of three groups. They were either randomized to double-blind placebo or double-blind citalopram or open-label citalopram. So the double-blind placebo is in green, the double-blind citalopram is in blue, and you can see that the open-label citalopram at week 8, in terms of response on the Hamilton rating scale, was significantly larger than when patients were blinded, presumably because they knew they were receiving medication, so the effect was bigger, and as a result of expectations. So these are really powerful effects that really matter for treatment response. So this is the picture of what's going on, most likely. So there are some non-specific effects that go into your placebo response. If you imagine this is group and this is improvement in symptoms. So part of your improvement in symptoms is going to be these non-specific effects. Natural course, regression to the mean, some of those biases that come up in trials. Part of it will be this true placebo effect that results from expectations, learning, biological systems. And then in your treatment response, it probably also includes both of those things, and then a specific treatment effect on top. And that's the difference that we're often measuring in clinical trials, which might be quite small. But that's the bit that would be specific to treatment. What we don't know is the relative size of each of these bars in different disorders. We recently completed an umbrella review. The protocol is published. The umbrella review is currently under review, where we looked at placebo effects across mental health disorders. So we looked at what's known about the effect size in different disorders, and this is within group. So there's change from baseline to end of study in placebo arms. And what you can see is a big variation. But anxiety disorders on the whole, which are around here, have one of the largest effects. In fact, generalized anxiety disorder had the biggest placebo effect that we found in meta-analyses of placebo effects. The other thing we found generally was that these effects were correlated with treatment effect. So you can see in the triangles here were where treatment effects were reported. Treatments were always superior, should point out, always superior to placebo. But the placebo didn't lag far behind most of the time. We don't know how correlated they are in anxiety disorders, but given these results, they probably are correlated. The placebo effect varies more than the medication effect. And because they're correlated, you probably end up with this situation. And I talk about this in a paper in European Neuropsychopharmacology, whereby in trials where you have very large placebo effects, you're likely to obscure your medication effect. So because that medication effect is so small, and we don't know what the ceiling is, if you have a very large placebo effect, there is some evidence to suggest that gets obscured, which is a problem. It means that, weirdly, you're actually approving these treatments down here most of the time because they separate from placebo. But is this treatment really worse than this treatment? We don't know. Or is it really better, I should say? We don't know. It's a quandary, a conundrum that we need to work through. So, as I say, the size of these bars, we don't know. We don't know what the ceiling is either, and we don't know if it's different for different disorders. But given that the placebo response was wildly varied in different disorders, these bars probably do vary for different disorders. And so what I think we need to do is try and understand what the size of these effects are for different disorders and what drives them, and kind of one by one work those things out. So I've started with anxiety disorders because that's what we do most in Southampton, and I'm trying to understand what these effects are and what the size of them are. Which brings me to my first question, my first research question that I've been grappling with, which is, I mentioned before that placebo effects result from expectations and learning and effects on biological systems. So the first thing, what is the effect of expectations? How large is it on efficacy? By efficacy, I mean that difference between medication and placebo on your clinical trial. Well, there's not a good way of answering that question because we don't often ask people what their expectations are. But I had a very talented student who came up with an idea, which was maybe we could find out if people became unblind in clinical trials and use that as a proxy for their expectations and beliefs. So we tried to do this. So we systematically reviewed the literature from 1980 onwards, looking for all clinical trials in the main anxiety disorders, so generalized anxiety disorder, social anxiety disorder, and panic disorder. We kind of stuck to those three. and tried to find every clinical trial that had been published and any clinical trial that had been registered as well, looking for any unpublished studies. And the main thing we were interested in was people's guesses about whether they were on medication or placebo, and see if that data was out there. This is our Prisma flow diagram. I'm happy to say there's a preprint about this paper as well that you can look at. The link's at the bottom there. So we searched, and we did an updated search about a year later. We found about 11,000 records. And of those, we managed to get allocation guesses from only 9 trials. So we managed to include 248, and only 9 of them, which is about 3%, reported any kind of guesses about allocation. And that was even after contacting authors who had done the studies, finding out if there were any unpublished allocation guess data. And there were some, so we got 3 more, but still only a total of 9, which is not much data to work with, but we worked with it anyway. And we initially just meta-analyzed the results. So these are the trials that had allocation guess data. These are across social anxiety, generalized anxiety, and panic, looking at the effects of medication compared with placebo. And overall, which is nice, as you'd expect, we found a significant effect of medication with an effect size of about 0.4, which sounds about right. So that's a good start and promising. So we next tried to look at this measure of blinding integrity to get at people's expectations and beliefs. And we used something called Bang's blinding index to calculate this. So this is a simplified formula for it. Essentially, you take people who guess correctly and you take away the people that guess incorrectly over the total number of patients, and that gives you your blinding index. So that means that scores closer to 0 suggest intact blinding, whereas scores closer to 1 suggest unblinding, or in fact perfectly correct guessing. And then -1 would be opposite guessing, which I'm not sure why people would do that, but that could also signify unblinding if people were actively guessing oppositely. We actually only found numbers between 0 and 1, I believe. So yeah, scores closer to 0 suggest blinding integrity. And what we did was we took these numbers and we regressed them against the effect size of treatment to see whether degree of unblinding could explain those effect sizes. And we calculated this for both the clinicians, where we had the data to do that, and the patients, where we had the data to do that. This is the result for clinicians. Only 4 data points, so don't read too much into this, but it was significant. There's a significant relationship between unblinding, so scores closer to 1 here on the Bang's blinding index, and increased effect size of medication. That was true for both the treatment group, which is this group, and the placebo group. What does that mean? Well, we don't know exactly, because there's 2 things that could have happened. So one is the clinicians saw people getting better and said, I know which ones are on treatment and which ones are on placebo. And in some ways, that's okay, because that would fit. We would call that benign unblinding. That sort of unblinding would fit with the actual efficacy, so that's not a bias. But if people saw patients and saw some side effects that were specific to the medication, and that was what led to the guess, then this might signify some bias. So there's a signal there of something, potentially. In the patients, we saw quite a different picture. So there was 5 data points for this analysis. And interestingly, in the treatment group, we didn't find any relationship between blinding integrity and effect size of treatment. But in placebo groups, we did find a relationship here. So when the placebo groups were more unblind, the effect size of treatment was bigger. And one of a colleague on Twitter coined a term that might have explained this, which is nocebo. Did the patients who were in the placebo group, if they knew they were on placebo, did that lead to reduced expectations, disappointment, that exaggerated the effect of the treatment? Possibly. We don't know. Interestingly, around the same time we were doing this, there were two other studies published looking at, again, similar things in antidepressant trials. And like we did, found that less than 5% reported any kind of blinding assessment, but also were inconclusive about whether that affected the efficacy of treatment. So I have some recommendations. And I think that we should be measuring expectations, because blinding is good, but it is a proxy. We should be measuring at baseline, what do people believe the treatment is going to do for them? How much is it going to work? Does that change after randomization? That's also important. So they might have one expectation going into a trial and another after being fully informed and consented, etc. And then I think we also should be routinely collecting guesses about treatment allocation and what the reasons are behind those guesses. So did people say, oh, well, I saw this side effect in everyone who I thought was on treatment? Or was it, they got better, so I thought they were on treatment? And with the patients, what was their reasons for guessing as well? And that would really help us understand whether there is a relationship between unblinding and treatment efficacy. We could then explore that across trials. We just don't have the data to do that at the moment. So that's where we've got to with expectations. What about the other part of placebo effects that I mentioned, the biological systems? I've been trying to explore this as well. So which biological systems are involved in placebo anxiolysis? And I think there's some important reasons to do this. One is it might teach us some mechanisms about placebo effects generally. The other is it might tell us about mechanisms for how patients get better, whether that's because of medication or not, which might point to some novel treatment targets. We actually have quite a good understanding of which biological systems are involved in placebo effects in pain. This is from a review and meta-analysis in 2015 by Wager and Atlas. And on the right here, each of these dots represents a single study into placebo analgesia. And there's tens, we're looking at nearly 100 studies. An overall finding that there's these two kind of systems involved. There's a kind of motivational reward pathway and a kind of down-regulating cognitive pathway that goes through the periaqueductal gray that kind of regulates emotions as well. So we know those pathways are involved in pain, but do we know what's going on in mental disorders, and in particular in anxiety disorders? Well, I tried to find out. So we carried out a systematic review looking at whether the data were out there about functional neuroimaging correlates of placebo responses in patients with depressive and anxiety disorders. And we were quite broad with our inclusion criteria here. So we weren't looking for studies where the primary aim, although they might have been, but we also included studies where the primary aim was not looking at the placebo effect. But if they had imaging data from baseline and after placebo, showing which areas might have been involved, we included those. And even with those quite broad criteria, we only found 16 studies that have reported anything. And most of those were in depression. So 12 of them were in depression, only 4 in anxiety disorders. So we're really barely scratching the surface. This is what those 4 studies found. Generally, reduced amygdala activity was associated with symptom improvement, which makes sense, but I suspect that's not specific to placebo effects, because you see the same thing with treatment with CBT, with antidepressants as well. So it's not specific. There was one of these studies, which I should say were all in social anxiety disorder as well, so we don't know anything about any other anxiety disorders. But only one of these studies looked at expectations. It was, in fact, the study I mentioned at the beginning with that open-hidden paradigm. They did some imaging before and after and found that patients in the overt group had some different activity in the posterior cingulate, left temporal gyrus, maybe signals of the default mode network being involved, but it's very tenuous. There was one study that was published after we did that review, which I do just want to highlight because it is relevant. And that was this study, again by the same group as all those other social anxiety disorder studies, and again using the open-hidden paradigm. So like before, they randomized patients to receive either escitalopram openly or escitalopram with instructions that it was an active placebo. And they did a public speaking task before treatment and after treatment with PET imaging. And this group were interested in the function of serotonin and dopamine in these patients. And this is what they found. So as before, the overt treatment was significantly superior to the covert treatment. But the bit that probably I'm most interested in, the neurotransmitters, you can see serotonin occupancy, there wasn't much difference between the two groups, which you'd hope because they both received SSRIs. But there was a difference in dopamine between overt and covert. The overt group showing more dopamine activity, bigger change in the binding potential. It looks like it was located there in the ventral striatum as well. Which is potentially relevant. So maybe what we're seeing here is there's a non-specific marker of treatment response, something about dopamine rather than serotonin in patients with social anxiety disorder at least. But there was no placebo arm, so we don't know whether it's got something to do with the SSRI or not. Possibly one of the reasons that we don't have much data about the biological systems involved in placebo effects in anxiety disorders is that unlike placebo analgesia, we have very few models to study it in a laboratory setting. So placebo analgesia, it's quite easy to induce pain in the laboratory, condition some sort of treatment with that, and see a response. It's only been attempted once before in anxiety disorders, and it was by this group, by Mayer and colleagues, reported across 2 different papers. This is a schematic of their paradigm, which is quite complex, but essentially healthy volunteers were given a threat of shock. So on some trials, these red trials, there was a threat that they might get an electric shock, and on other trials, the green trials, there was no threat. The thinking being that the threatening condition was a model of anxiety, as it were. And then sometimes the patients were given a placebo, so they were given a nasal spray that was salt water, labeled as lorazepam, and on other trials they were given just the normal saline. And they compared those 2 effects. But what they found was that anxiety reduced kind of globally across all trials when they were given the lorazepam. So it's unclear whether it was related to threat or not. There's also problems with this in that if you're causing pain, how do you know the mechanisms are not related to placebo effects in pain and not in anxiety? And finally, I would argue this model is not a very good model of anxiety disorders. You know, the anxiety is kind of relevant. You know, you're in a situation where you might get shocked and cause pain. I think that would be quite warranted anxiety. Whereas in anxiety disorders, you know, the anxiety is usually uncontrolled and out of keeping in the situation. So we use a model in Southampton for kind of proof of concept studies with treatments in anxiety disorders called the 7.5% carbon dioxide model. And in this model, we bring healthy volunteers into the lab. They inhale air that's been enriched with extra carbon dioxide, so 7.5% carbon dioxide. Same amount of oxygen so that people don't suffocate, which is important. And we know that mimics the subjective and autonomic effects of generalized anxiety quite well. This is one of the seminal papers using this model by Bailey and colleagues, showing that people's subjective anxiety scores are significantly higher under the CO2, and also that their autonomic measures are significantly higher as well. So systolic blood pressure, heart rate are significantly higher too. And we know that this model is responsive to standard treatments. So if you give people lorazepam, they have less anxiety. A week of duloxetine also works as well for reducing anxiety in this model. So I think it has quite good face validity for clinical anxiety. And so I tried to use this model to make a laboratory procedure for inducing placebo effects in healthy volunteers. And I'm pleased to say this has just been published in International Journal of Neuropsychopharmacology, which is good. So this was how the study worked. So healthy volunteers, 32 of them, came in to the lab and had a baseline CO2 inhalation for 20 minutes, which got them nice and anxious and gave us a baseline measure. And then they were randomized to one of two groups. So in the first group, they were given a nasal spray that was salt water that we labeled intranasal lorazepam. And we gave it to them with instructions that this was intranasal lorazepam, it would reduce their anxiety, and would work quite quickly as the nose is directly connected to the brain. And then we did a repeat inhalation, but unknown to the participants, we surreptitiously changed the gas from CO2 to normal air. The thinking being that their anxiety would reduce here, and they would attribute that to the nasal spray. We then gave them another dose of nasal spray, with the same instructions that this was intranasal lorazepam and it should help their anxiety, and then did another 20-minute inhalation, but this time giving them the carbon dioxide again. And so we were interested in the difference in anxiety from here to here, and any reduction there, we would say, was due to the placebo that they had been given. But to ensure that was the case, we had another group where we were completely truthful. So in this group, we gave them a saltwater spray, but told them that it was salt water. We told them that they were about to inhale air rather than carbon dioxide. And so if they felt better, it would be because of that. And then we told them again that they were having the nasal spray, the saltwater nasal spray, and that they would then be inhaling carbon dioxide. And so if they got anxious again, that would be why. And the idea here was, we thought that probably there would be some natural relaxation, there would be some kind of difference anyway, and so this group would control for that, just kind of the time course of the experiment. So then we could hopefully measure what was genuine placebo effects. So what did we find? I was quite surprised by these results. These are our subjective measures. And along here, we have time in the experiment. So this is before the first inhalation, after the first inhalation, after the air inhalation, and after the second carbon dioxide inhalation. And the red group is the lorazepam group. The blue group is the saline group, the group that we were truthful with. And you can see across all our subjective measures, so measures of anxiety with the GAD-7, panic, emotional measures, there was absolutely no difference between the groups whatsoever. I was very impressed with how little difference there was, if I'm honest, because it's quite surprising. We've done something quite different to both of them, and yet they've both responded in exactly the same way. This is good for the carbon dioxide model, I should say, but less good for my placebo research. This was despite inducing quite a positive expectation. So the lorazepam group here in red, you can see we measured their expectation of how much the spray would reduce their anxiety before the air inhalation and after. And you can see that after the air inhalation, they really believed that the spray was reducing their anxiety. It was significantly higher. And you don't see the same thing in the saline group. So that seems to suggest that they did believe the instructions, and yet there was no improvement in their anxiety symptoms, which is odd. So we looked at what each person did. We looked at change in their reactivity to carbon dioxide, so from baseline and after the placebo. And what we saw was there were some participants in green who really improved, and there were some in the purple here who got worse, which was unexpected. Often in similar kind of placebo studies, when you see the within subject data, most people improve. Hardly any get worse, but we saw quite a few people get worse. So what could be going on there? One possible explanation might be if placebo effects result from a kind of Bayesian predictive coding framework. And this is how this predictive coding framework works. So if you imagine you have a stimulus intensity here, and just for this cartoon, it's from 0 to 100, and you have some kind of belief about what stimulus intensity might be about to be. The important thing about that belief is it's probabilistic, so it has a probability and a density, so it means it has a certainty associated to it. So you have some kind of degree of belief and certainty. You then have a noisy observation. This is incoming data that's coming in through your nervous system that also has a certainty attached to it, right, based on how strong that stimulus is. So what your brain does is it makes a Bayesian inference. So it takes this data about what it thinks is going to happen, this data about what it's detecting, and says, okay, so probably the stimulus is about here. And that difference between the red curve and the green curve, that's your placebo effect. What's interesting is if you think about situations where you're changing the relative certainty of different things. So if you imagine, and I think this may have been what happened in our CO2 study, if you have an expectation with low certainty, this is kind of here, you sort of have a vague expectation, but you don't really know. And then you have a stimulus that's very intense and without much noise. If you've ever done the CO2, the carbon dioxide, it's very intense. And with higher concentrations will cause panic attacks. So we may have had this really intense observation. Well, probably your brain is going to weight the perception more towards the really certain stimulus. Or it may even abandon the expectation altogether and catastrophize. And it might even make the stimulus worse, which may have happened in some of our participants. Sadly, we did not record data of what participants thought and felt during the experiment, which would have really given us an idea about whether this was going on. But this is something I want to explore, is could this be explaining what happened in our study? And therefore, does that make it really quite tricky to kind of induce and study placebo effects in anxiety disorders? Probably yes. So, where have I got to in this? Well, we haven't really got very far. There are many research questions that we really need to explore and understand to make progress with this. So we need to know, what are patients' expectations in clinical trials? Does that interact with people's beliefs about what treatment they're actually receiving? And does that affect the outcome? If so, how are they interacting? We need more data about that to be able to answer those questions. I think we really need to be working out which biomarkers are specific to treatment response and which are non-specific, and if there are any that are specific to placebo. And I think, that could potentially be a different readout from clinical trials rather than the difference between symptom improvement. Maybe you can measure some biomarkers that are specific to treatment, and you can say that's the treatment response. And finally, and I think this is relevant to the clinic as well, we saw in a study where we tried to use expectations to induce a placebo effect that it didn't work. Something changed that expectation model. If so, what information updates it? And in particular in the clinic, if you've got a really strong positive expectation, you don't want that to go away. So how do we update it the least? And how do we use that in clinic to maximize the effects of our treatment? I think that would be really important to explore. So I just want to thank everyone who's been involved in these studies, so particularly my supervisors, David, Matt, Samuele Cortese as well, and everybody else who helped with data collection, and my funders, the MRC and the NIHR. And I'm happy to take questions and have a discussion.